This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. Falls are a big deal with our patient population, but do you find yourself struggling to manage or even prevent falls with your patients? You should check out AGPT's clinical guidance statement on the management of falls in community-dwelling older adults. This paper gives you a clear direction, recommendations, and action steps so you can help your patients. You can get this article for free and learn about how the AGPT can further your clinical practice at geriatricspt.org/SRP. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hey there, Senior Rehab Podcast listeners. This is Erinn Carey.
And I'm Tali Spaceman.
And you're listening to SR Prereqs. So today, we are going to talk about an article entitled Rehab Needs for Elderly Patients with Cancer.
Okay, very good. It's a subject that we should talk about as there are so many older people with cancer.
Yeah.
Because it can go in different directions, this article. So I'm excited to see which direction they're going with.
This was published in 2016 in Physical Medicine and Rehabilitation Clinics of North America. 2017.
Cool. Where was the study done?
So the three authors are all in New York City. The first one is Padro-guzman. He's a physiatrist at Memorial Sloan Kettering, which is like a premier cancer center.
Yeah, they know a little bit about cancer.
The other two authors are Jennifer Moody and Jessica L. Au. They're both physiatrists at New York Presbyterian Hospital. So this is not a study. This is like expert opinion based on research on management of older adults with cancer. They say elderly patient, but we're just going to change those words.
To older, we'll change. Okay, cool.
Because we're progressive. So, like I said, these are all physiatrists. So this article is specifically aimed at physiatrists. So there's a little bit more about medication management that I'm not really going to go into. The link to the abstract is in the show notes. So if you feel like using your institutional access to go find the full text of the article to look up the dosages of ibuprofen, I respect your right to do so.
All right, go ahead.
So they talk about the background, physical assessment, pain, fatigue, lymphedema, and bone health. Those are the five sections of this article. So I'm going to start with the background. They state that in 2030, they estimate that 70% of all cancers will be in people over the age of 65 years old, with the most common being prostate, breast, lung, and colorectal. 70% of all cancers in people 65 and older. If that doesn't make it clear to you that understanding the management of persons with cancer isn't important, stop.
It's okay to be a little apprehensive, and I respect that when you're saying, wait, I can't treat them like any other patient that comes to me after a hip replacement. It's something else, and I need to research it, but not to say, you know what, I'm not taking people with cancer.
Yeah, it's just, I'm not into it.
Because I had two patients that came to me that came after, but no one would take me because of the cancer. One of them had back pain, and he said nobody would take me because of the cancer.
Did they have an MRI?
Yeah.
Were there METs to the spine?
No.
Well, then why not?
It just, again, some clinicians are very apprehensive and are afraid of either a malpractice lawsuit or making things worse, thinking they're not adequate, but we are clinicians, we are professionals.
Although I think about it, and there are definitely situations where like there are some patients that are within the Practice Act to treat where I'm like, this is over my head. That being said, that encourages me to learn more about it, not to be afraid and push them away.
Yes. All right.
So older adults with cancer are consistently undertreated. They are less likely to receive chemo, radiation, and in prostate cancer, prostatectomy, despite that being the gold standard treatment for prostate cancer. And the physiatrists speculate that one reason is a fear of intolerance to more aggressive therapies in the elderly, meaning that they are more likely to have complications leading to confusion, syncope, and future falls. Mm-hmm. Okay, so that's pretty much it for the background. Cancer rates going up in the older adults, and they tend to be more conservatively treated than their younger counterparts. So that's just the overarching background of this article. Next, they talk about the physiatric assessment of the elderly patients with cancer. So the things they look at are things like the level of independence, the use of durable medical equipment, the history of falls, the previous cancer treatment types, social support, recreation, emotional needs, cognition. It's all very familiar. Like these are all things that we would look at in our assessments too. They recommend the use of standardized functional measurements such as the tug or the single leg stance, anything to assess the risk of falls basically. Older adults with cancer may be at higher risk for falls than older adults without cancer. There is some evidence to suggest that.
Yeah.
The specific tool they suggest using is the Comprehensive Geriatric Assessment, or the CGA, and there's going to be a link in the show notes with the description of how to use it.
Okay.
Yeah. So it stratifies people into 3 different categories: fit, vulnerable, and frail. The people who fit into the fit category are in good or excellent health, they have functional independence, and they have no medical comorbidities and no, quote, geriatric conditions. I might be stupid, but what's a geriatric condition? Are they just conditions that are more prevalent in the older adult population?
I think that they are maybe conditions that are more prevalent in the geriatric population.
Okay. I was trying to find the source material for more specific examples of geriatric conditions, and they said, like, depression.
Yeah.
People of all ages get depression.
Yes, but there's a certain geriatric depression.
Oh, like it's different. It's like different physiologically. You treat it differently.
You do treat it a little differently. It depends. If it's a geriatric, if it's a depression that the onset was at older age, or a depression that the person, either it's a recurring or chronically depressed since their 20s, 30s, or earlier on. They are a little different, especially when it comes to dosage.
I see. It's kind of like different types of Alzheimer's, like early onset versus late onset, are treated differently.
Yeah, and also...
and have different expectations and prognoses.
Also, if the depression is related to Parkinson's or dementia, as opposed to an acute depression.
Interesting. Okay, that's really helpful. Thank you.
No problem.
So then the vulnerable category, they are in fair or good health. They are independent in their ADLs and need some help with IADLs. They have mild comorbidities and mild geriatric conditions. And this is where they said depression, cognitive deficits, and risk for malnutrition.
So that's what they define as geriatric conditions?
Yeah, those are the examples. Okay. The depression, cognitive deficits, and risk for malnutrition.
Okay, because my worry was that they didn't define what geriatric conditions are, which is that's a little risky or inappropriate.
I think that the authors of this article assume that we have some familiarity with the Comprehensive Geriatric Assessment, because it's outlined a little bit more in that. Then it defines the frail as people in poor health, people that require assistance with their ADLs, have 3 or more medical comorbidities or 1 life-threatening comorbidity, and they have these geriatric conditions. So fit, vulnerable, frail.
Yeah.
So a strong predictor of mortality in patients with cancer, regardless of age or disease stage, is this stratification in the Comprehensive Geriatric Assessment. So people who are considered to be fit have better prognoses, can tolerate more aggressive treatments, and people who are frail are not going to tolerate it as well as someone who is fit. However, the vulnerable population in the middle, there's really no one way or the other of how they're going to tolerate treatment. What the author suggests is that people who fall into this vulnerable category in between the fit and the frail receive rehab to push them into the fit category to better tolerate cancer treatment.
Ooh,
yeah.
Okay. Yeah, that's a nice way to put it, of like how can we help the one in the vulnerable? Because obviously, it's not that we can't help frail. Obviously, we can.
We're going to do it in different ways.
But yeah, help the ones in vulnerable into fit, because then their survival rate is better.
Yeah. Okay, so that's pretty much it for the physiatric, I don't actually know how to say it, their suggested assessment for patients with cancer. Next, they're going to talk about pain in the geriatric patient with cancer. Any questions before we move on?
No.
So 2/3 of patients with cancer have pain from either the cancer itself or the treatment. And older adults additionally have pain from degenerative changes of the joint and spine. And they put it into 2 general categories, the first being nociceptive pain. The article recommends treatment with things like acetaminophen, although be careful with the liver, NSAIDs, but got to be careful about those GI bleeds, and avoidance of opioids to older adults due to older adults being prone to neuropsychiatric sensitivity. And then the article expounds on the medication management. Like I said, it's not super important. Just know that opioids can cause constipation, and walking is helpful for that.
Did they say anything about medical marijuana?
They did not mention it. And, considering that this was published in 2017, I would expect them to bring it up.
I would really expect it, just because it's one of the well-known drugs to actually help both pain and appetite in people with cancer.
Right. They do say herbal supplements, but they don't describe. Oh, yeah, they do. They say ginger and turmeric.
No, it's not the same.
Yeah, right.
I don't know if any of you try to smoke ginger and turmeric. No, just kidding.
Please don't.
And I used to work in a pain clinic, and we had a lot of older adults that came battling with cancer, and that was one of the populations that usually doctors did not avoid or procrastinate giving prescription for medical marijuana, because they assumed that they're not going to abuse it. They're not just going to, invite their friends for a party, for a cancer party.
They might, but no one's going to overdose.
Yeah.
I'm from Colorado. I can say that.
People overdose for marijuana?
No, never in the history of weed.
I've never heard.
That's because it's never happened.
Yeah. Okay, I'm just surprised that in a study that talks about treatments of cancer, that was not, and of cancer pain, that was not.
That is a good point. Although, if you think about it, medical marijuana in New York is really, it's legal here, but I think there are maybe 3 dispensaries in the entire city of Manhattan. I'm sorry, in the entire city of New York City, in all 5 boroughs. So it's very tightly regulated. So I think that it's probably not on their radar as far as a treatment option, because they don't encounter it because they really can't.
Huh. That's
my guess. I don't actually know these people.
Okay. I'm not going to get into it because it's a little political, and I try to avoid that.
There are medical refugees, or what we call them, where people with kids with epilepsy and terrible spinal cord injuries, and who would just come and live in Colorado so that they could get the medical marijuana to treat their ailments. Yeah, medical refugees are a real thing.
Wow, okay.
Yeah. Have you ever tried driving in Colorado?
I never been to Colorado.
Oh, that's right. It's terrible ever since weed became legal, because everyone is coming. Mostly for the recreational, but there are plenty of medical refugees out there.
Okay.
Yeah.
Good to know.
And now they're all going to go to Vermont. So, Mariana Winegood, have fun with them.
Okay, cool. Thanks.
Then they talk about neuropathic pain. It's very common in patients with cancer, and the treatment of choice that physicians tend to choose are things like anti-epileptics and antidepressants, although they specifically said tricyclic antidepressants.
Yeah.
I thought those were kind of falling out of favor.
Yeah, but when it comes to depression that also combines pain, those are usually. And a lot of time that when somebody does not admit they have depression or does not want to take drugs for depression,
right?
But they have pain, the doctor would say it's for your pain, but it's actually for both.
Interesting.
And also the neuropathic pain is both from cancer and from radiation.
Yeah.
A lot of times from radiation and chemo.
You just need to watch out for the side effects. So tricyclic antidepressants have cholinergic side effects. So then they also, to treat pain, they also suggest physical therapy, psychotherapy, massage, herbal supplements, which, we'll just call that weed. They didn't say it, but we know.
But maybe it's this turmeric and ginger thing.
I think they later said turmeric and ginger, and I was like, no, next. Although, actually, okay, I should be fair. I haven't read any source material on studies looking at ginger and turmeric for pain relief. I'm just very skeptical because I'm a bit of a negative Nelly. So they also suggest acupuncture as well. They also take the time to point out that physical therapy and exercise has been shown to improve pain and fatigue in patients with cancer. Specifically, patients who are status post-mastectomy, the rehab program should include things like pec stretching, muscle strengthening, soft tissue mobilization, and posture and biomechanics strengthening. And they've found that massage improves quality of life in patients with end-stage cancer, which I could see that. That makes sense. So that's pretty much it for pain. Next is fatigue. Cancer-related fatigue has a prevalence of 70 to 100% of oncology patients. That's all of them.
Yeah, it is tiring to fight cancer.
I believe it.
It is tiring. There's a growth in your body that doesn't belong there.
And it's just eating up all the food. It's rude. And then you put terrible things in your body like methotrexate. Ugh. So the definition of cancer-related fatigue is distressing, persistent, subjective sense of tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity that interferes with usual functioning. And it does not improve with rest, and the mechanism is largely unknown. So older adults having cancer-related fatigue can lead to functional decline, increase morbidity and mortality, and reduce cognitive performance. So this cancer-related fatigue is a big deal. Non-pharmacological treatments that they suggest are strengthening or endurance-based programs, psychosocial interventions such as fatigue education, stress management, and relaxation techniques, and they found that exercise is safe and effective at reducing cancer-related fatigue, improving quality of life, and preventing functional decline.
Did they say what type of exercise?
Not in this article, but in the source material.
Like, aerobic, non-aerobic.
So they mention source material, which is behind a paywall, so I didn't have the chance to look at it.
Okay, fair enough.
The pharmacological treatments that they suggest for cancer-related fatigue are psychostimulants and antidepressants.
Okay.
Yeah.
Do they just assume that the fatigue is related to depression?
No, they're assuming it's related to the cancer.
Okay, so why the antidepressants?
I'm not a physician. I have no idea.
Okay.
I would ask a pharmacist. All right, on to lymphedema. So lymphedema is super common depending on the extent or location of previous surgery and radiation and removal of lymph nodes and things like that. 30% of patients with breast cancer develop breast cancer-related lymphedema, with the incidence and severity increasing with age.
Only 30?
Only 30.
I mean, I assumed it would be more.
No, I mean, the surgical techniques get better and better. And for severe cases of lymphedema, they actually talk about microsurgical or microvascular procedures where they do node transplants, which have some pretty good results. Although it hasn't been studied in the older adult population as of this paper, so we don't know if it's effective for those over 65.
Okay.
So early intervention of this lymphedema is essential. Exercise enhances lymph flow and protein reabsorption. They also suggest low stretch wrapping, teaching manual lymph drainage, fitting compression garments, and education on proper skin care, such as washing with a mild soap and water and using alcohol-free moisturizer. This is where, so you know how we were talking about patients that you don't really know how to treat? A patient who has lymphedema, I'd be like, oh, someone else.
Oh yeah, but that's why there's a certification for lymphedema.
Yes. Yeah. And I am not interested in it at all.
I'm very interested in it. I wish it wouldn't take, it's a very long and expensive certification. Otherwise, I would take it.
Well, if you ever do, I will refer all of my lymphedema patients to you.
Oh, all the way from Washington to...
Yeah.
Okay. I mean, I would love to do lymphedema. I think it's one of those things that really, really help. And a lot of patients neglect it because they... You know how there are some things that our patients think it's... Oh, this is how it's going to be from now on. There's nothing I can do about it. So right. I better just live with it.
Yeah.
And then they meet someone that says, there are some things you can do. Really?
It's like pelvic floor health.
Exactly. And it's the same family because it's one of those pathologies that mostly women have.
Mm-hmm.
And as women, we suffer a lot of things because that's how it is.
Life is suffering. What are you talking about?
And that's in life and our body. We're like, oh, that's how it is, leakage or...
Pain
or... Yeah.
This is just how life is.
Yeah.
So, education. So then they talk about, like, we've discussed the surgical interventions, but we don't know how it would work for the older adult. All right, on to bone health. Patients with cancer are at higher risk of osteoporosis and osteopenia, and these patients have a higher risk of morbidity and mortality. So things like breast cancer drugs, such as aromatase inhibitors, doxorubicin, methotrexate, glucocorticoids, these all cause and worsen osteoporosis. These are very common chemotherapy drugs.
Yeah.
Yeah. If your patient is undergoing chemotherapy, it's worth taking a look at their list of medications and looking at their potential side effects, because say they're suddenly osteopenic and they're used to doing things and then they fall and, oh, bad, not good. Also, patients with prostate cancer undergoing androgen deprivation therapy are at high risk as well. Patients with new diagnosis of breast cancer are 5 times more likely to develop vertebral fractures than the rest of the population. So the recommendations that these physiatrists put forth are 30 minutes of weight-bearing activity daily, plus calcium and vitamin D supplementation. So apparently bisphosphonates are helpful, but the side effects of those include fatigue, bone pain, anemia, which older adults are at higher risk for experiencing due to their decreased renal clearance. So that's pretty much it. They have a little summary of like, well, you should be careful and look at medications, and patients with cancer are inherently interdisciplinary and communication is key. So this article only looks at patients with cancer undergoing cancer treatment, but it doesn't address patients in remission, which, like, when we're talking about things like cancer-related fatigue, that can persist 20 or more years after the cessation of treatment. So even though you have a patient who does not have cancer anymore, but has a history of it and they don't even bring it up, you know what I'm saying? History is important.
Yeah.
Cool. That's what I have for this article.
Okay. Yeah, it's a great subject to talk about, again, because there are a lot of older adults with cancer. And although we do not treat the cancer, we do treat the person with the cancer.
And the symptoms they're experiencing that make it more difficult for them to live their lives.
Yeah. And we live now in an era that cancer is not necessarily a death sentence.
Depending on the cancer.
Definitely depends on the cancer and other factors. And about specific cancers and about locations. I never had a patient with cancer that I thought, oh, I can treat them without reading or without asking other people. I always consulted with oncologists and with nurses that treated people in hospices and other institutions. Because again, I do not know a lot about it, but I do know that my client has it and he needs me right now, or she needs me right now.
Thank you all for listening to SR Prereqs. I'm Erinn Carey.
And I'm Tali Spaceman.
And as always, stay funky.
Hit me! Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers, where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.